Guys, I am Dr. Monisha. Welcome to One Question at a Time series. We'll move on to today's question. Today's question is the most common diaphragmatic hernia is it a Bogdack's hernia, Morgagni's hernia, paraesophageal hernia, or none of the above? Okay, for that we should have a little bit knowledge about the diaphragm. So, why is a diaphragmatic hernia? Any defect in the development of diaphragm, or if there is a weakness in the diaphragm which is going to form a partition between the thoracic cavity and the abdominal cavity, is going to give rise to hernia of the abdominal contents into the thoracic cavity and thereby compromising the structures in the thoracic cavity. So any defect in the development of diaphragm is going to cause diaphragmatic hernia. A little bit about the diaphragm. Diaphragm has a central tendon part, okay, semilunar central tendon part, and a peripheral muscular part having the attachments to the ribs and the sternum, called as the sternal part and the costal part, and we have the right truss and the left truss of the diaphragm. So this is about the basic structure of diaphragm. So about the openings of diaphragm, we have an opening in the central tendon at the level of T8 vertebra for the vena cava and the right phrenic nerve, and we have an opening in the right truss of the diaphragm at the level of T10 for the passage of esophagus and its vaguses, and we have a passage for the aorta at the level of T12 just behind the median arcuate ligament connecting the two crusts of the diaphragm. We have the median arcuate ligament. So the aorta is going to pass behind the median arcuate ligament. So we have these three openings, one for the vena cava, the second one in the right truss of the diaphragm for the esophagus, and third one for the passage of aorta just behind the diaphragm. It is not actually within the diaphragm, it is behind the diaphragm. Okay, so and we have numerous other multiple openings for the passage of small vessels and nerves. So this is about the basic structure of diaphragm. We need to talk about a little bit about the development of diaphragm. The central tendon part is going to develop from the septum transversum. Okay, and the posterolateral part, this triangular part, is going to be formed by the pleuroperitoneal membrane that is going to cover your pleuroperitoneal opening. Pleuroperitoneal membrane is going to form the posterolateral part, and the dorsal mesentery of the esophagus, from here it is going to form the crural part, and the peripheral body wall is going to contribute to some of the peripheral part. So these four structures contribute to the development of diaphragm: septum transversum, pleuroperitoneal membrane, okay, dorsal mesentery of the esophagus, body wall. Okay, any compromise in the development of any of these structures is going to cause hernia. Most often the pleuroperitoneal opening is compromised. The pleuroperitoneal membrane fails to close the pleuroperitoneal opening, that gives rise to hernia. We'll see about that. So 90% of the times the pleuroperitoneal opening is failed to get closed by the pleuroperitoneal membrane, most often on the left side, giving rise to Bogdack's hernia. Okay, the posterolateral part, which is going to be formed by the pleuroperitoneal membrane, fails to close the pleuroperitoneal opening on the left side, most often on the left side, giving rise to Bogdack's hernia. And in some cases, between the sternal and the costal organs of the diaphragm, there is an opening, okay, most often in the right side, okay, anteriorly between the sternal and the costal organs of the diaphragm. Okay, there is a triangular opening. which gives rise to Morgagni's hernia. So 90% of the hernia is Bogdalek's hernia, and the remaining 9% of the hernia is Morgagni's hernia. So what about the remaining 1% of the hernia? We'll see it. So this is a picture of Bogdalek's hernia, where there is a large opening on the posterolateral aspect. So there is herniation of the abdominal contents into the thorax. So you can see all the bowel loops in the thorax occupying the thorax. See here, the left side of the chest is occupied. Okay, so the Bogdalek's hernia is more common on the left side. So it is going to compromise the left lung and the heart, and most often the cause of death is due to pulmonary hypertension and respiratory failure. Okay, so this is an x-ray of Bogdalek's hernia, and the remaining 1% of the hernia which we didn't talk about is the paraesophageal hernia. We saw that the right truss of the diaphragm has an opening for the esophagus. If the opening is a little bit large, okay, if the opening for the esophagus in the right truss of the diaphragm is a little bit large or weak, what happens is the fundal portion of the stomach herniates into the thorax. Like you see in this picture of barium meal, the fundal portion of the stomach has herniated into the thorax. Here you can see the shadow of diaphragm. So it has gone into the fundal portion of the stomach has gone into the thoracic cavity. Most often it does not give rise to very morbid symptoms other than acid refluxes, which can be treated medically. Okay, so this is about the development of diaphragm and its defects. So question for you is, so many pathways are happening in the development of diaphragm, but what signaling pathway is most often involved in the development of diaphragm? That is your question. Find out the answer and comment in the comment section. So coming back to the question, what is the most common diaphragmatic hernia? Obviously 90% of the hernia is Bogdalek's hernia. So the answer is Bogdalek's hernia. So for those participants who wants more about the development of diaphragm, here we go. So here is a picture of developing embryo where you can see the cranial most septum transversum, the cranial end of the embryo, and this is the caudal end of the embryo. In the cranial end of the embryo, you can see the mesoderm, septum transversum, which is going to contribute to the central tendon of the diaphragm. Okay, the septum transversum is seen in the cranial most region. Okay, so here is a picture of the embryo after the craniocaudal fold has happened. Okay, you know that craniocaudal folds and lateral fold happens. So this picture is after the craniocaudal fold has happened. So the septum transversum is coming to lie below your developing heart, just below your developing heart. So the septum transversum is destined to develop the diaphragm, separating the thoracic cavity from the abdominal cavity. So here is your next picture. So this hollow space is your intra-embryonic coelom that is going to give rise to all the cavities, namely the pericardial cavity, the pleural cavity, and the peritoneal cavity. Okay, it is going to give rise to all the cavities. So you can see the developing lung buds here. Okay, the lung buds are going to burrow into the body wall. Okay, so here you can see the picture of lung buds burrowing. So there is a developing pleural sac, and above that you can see the pericardial sac. This is a coronal section view of the embryo. Can you imagine the coronal section of the embryo? So you can see the pericardial sac. On either side you can see the developing pleural sacs. Just below you can see the peritoneal sac, and here you can see the mesoderm lying The septum transversum. Can you see it? The septum transversum. So, what happens is, can you see? But as lung buds are evaginating into the body wall, what happens is there is invagination. There are two openings. What are the two openings? Between the pericardial cavity and the pleural cavity, you have the pleuropericardial canal. Okay, you have this part is here, this communication is here, pleuropericardial canal. Between the pleural cavity and the peritoneal cavity, you have the pleuroperitoneal canal. This pleuropericardial canal is going to be closed by the pleuropericardial membrane. Okay, this pleuropericardial canal is going to be closed by the pleuropericardial membrane. It is nothing but as the lung buds are evaginating, these membranes invaginate. See, can you see the invagination of this membrane? So this invagination is going to close the pleuropericardial opening. So the membrane is called pleuropericardial membrane, otherwise called as ridge of Mal. Ridge of Mal. This pleuropericardial membrane, as you can see here, is going to contain two structures. What are these two structures is? Those are the phrenic nerve and the common cardinal vein. Okay, the two structures are the phrenic nerve and the common cardinal vein. Just remember this. Okay, so this pleuroperitoneal opening is going to be covered by the pleuroperitoneal membrane. Okay, so here you can see the esophagus. Can you see the esophagus here? And we have the mesoderm in front of the esophagus, that is here. Mesoderm in front of the esophagus, that is here ventral mesentery, and mesoderm in the back of the esophagus, that is here dorsal mesentery of the esophagus. So this pleuroperitoneal membrane is going to fuse with the ventral mesentery of the esophagus, and this pleuroperitoneal membrane is going to fuse with the dorsal mesentery of the esophagus. Okay, pleuropericardial membrane is going to fuse with the ventral mesentery of the esophagus, and pleuroperitoneal membrane is going to fuse with the dorsal mesentery of the esophagus. So we'll move on to the next picture. So here the pleuropericardial membrane has invaginated completely. So you can see the lung buds fully invaginated, and the structures phrenic nerve and the common cardinal vein running on the medial aspect of the lungs. Okay, because of the invagination of the pleuropericardial membrane and its fusion with the dorsal ventral mesentery of the esophagus. And here you can see the pleuroperitoneal opening waiting to be closed. So the interesting aspect here is, see, the phrenic nerve is a somatic nerve that is going to innervate the skeletal muscle, the diaphragm. But unlike the other somatic nerves that are going to lie in the periphery of the body wall, this phrenic nerve is lying on the medial aspect of the lungs. The only somatic nerve that is lying on the medial aspect of the lung is here phrenic nerve. Okay, and that is an interesting aspect. So finally we have the septum transversum forming the central tendon part. So the pleuropericardial opening is closed by the pleuropericardial membrane, and we have the pleuroperitoneal membrane closing the pleuroperitoneal opening. Okay, and here we can see the dorsal mesentery of the esophagus, okay, contributing to the crural part. But from where does this muscular part develops? This radial muscle fibers, this muscular part, where does it develop from? How does it develop? Okay, so at first the diaphragm was lying in the cervical vertebral level. To be more specific, it is lying against the C3, C4 and C5 vertebra. So the muscle cells and the nerve cells from the cervical somites has migrated to the septum transversum and the developing pleuroperitoneal membrane, and that is how we have the radiating muscular fibers. Because the muscular fibers have their origin from the cervical somites, the nerve supply is also from the cervical somites level, that is here C3, C4, C5. And though by means of the craniocaudal fold, the diaphragm comes to lie at the level of T12, the nerve supply is by the phrenic nerve, which has a root value of C3, C4, C5. Very interesting aspect. Okay, the diaphragm, because of the craniocaudal folding, has come from the cervical vertebral level to the T12 vertebral level. Though it has come now by means by development means the muscle cells are from the cervical somites, and that's why the innervation is also by the same somites, that is here phrenic nerve, and that is how the course of the phrenic nerve. Okay, so evolutionarily they say in the lower animals only the septum transversum part was there and there was no muscular part, and only on evolution the muscular part has developed, uh, muscular part has developed, which has very interesting functions, many interesting functions, like the means of creating a negative pressure in the thorax. Okay, which helps in filling of the ventricles. Okay, so and also many other things. Okay, and it is a powerful inspiratory muscle, as we all know. Okay, so evolutionarily the humans have tend to develop the muscular portion of the diaphragm. Thank you all.